Here's the big question this show answers. How do we leverage technology and human science to positively impact our personal and professional life? The Tech Human Experience has the answer. Here's your host, Inc. 5000 tech founder, neuroscience junkie, and Navy SEAL wannabe, Javier Guerra.
Hello, my fellow tech humans. Today's guest brings over 20 years of healthcare administration experience, including serving as an associate vice president of telemedicine at Geisinger Health System, and currently leading a consulting firm focused on digital health. He's not just a digital health expert, he's a team builder committed to enhancing patient lives and a strong believer in ongoing education within healthcare. Please welcome David Fletcher. Thanks for joining us today, David. It's an interesting space that you're in, right, with healthcare and COVID and all of the changes that have been coming at the industry and at the world in general. I'm really interested to talk, a little bit more about your background and your experience, and really kind of tap into some of that wisdom that you've acquired over the year-long period in this space.
Yeah, it's been an amazing few years. It's been a sea change, really, in the industry, no doubt.
Yeah, I bet. It's we work with a lot of healthcare companies, and it's definitely a good place to be in healthcare because people are, not going to have any less need for healthcare, so to speak. So let's get started with the stat. The FCC reports that approximately 21 million Americans lack high-speed internet access, creating barriers for telemedicine. Accessibility is a significant issue in healthcare. How is your team / company / what is your take on tackling the challenges of providing telehealth to rural or less connected communities in the world, so to speak,
Yeah,
U.S.?
absolutely. It's a real challenge, and I think that a couple approaches I've taken in the past, are kind of trying to work at it at a macro level, and working with policymakers and funding agencies to try to get solve the underlying problem as much as we can and just improve access to broadband. And so, for example, at Geisinger, we actually got funding from the FCC to provide substantially reduced cost broadband to kind of very rural areas. But it's going to take a lot of time and a lot of resources to really make it available to everyone in the country. And so the other piece of that is then, okay, let's not just put it off until this problem gets solved. What can we do today to make sure that folks who live in very rural areas can still get access to some of the benefits that come with telemedicine? So the approach we took was, okay, if a patient doesn't have broadband in their home, we don't just say, well, sorry, you got to drive 2 hours into the tertiary care center. We would see if they had, within 10 minutes, did they live within a clinic that we operated with? And so we had telemedicine clinic equipment in most of our clinics. And so we would ask them when we were scheduling, okay, you don't have broadband. I see you live next to our clinic in Lock Haven, Pennsylvania, for instance. That has a cart. Can you drive 5 minutes to that clinic? They'll host you there, and then you can still see our subspecialist who lives 2 hours down the mountain. And so we kind of took that kind of regionalized approach to try to address a lot of those limitations to broadband.
Nice. I know that's a growing issue, right? Like in a lot of places, but how do you think things are going to change with technologies like Starlink? Right? I know it's still not quite there yet, but
right.
But it's huge of what's going on with Starlink.
Yeah, absolutely. I mean, I think the amazing thing is, obviously it's a huge need in rural areas throughout our country, but then really throughout the world. The nice thing is, in theory, we could have, say, some of the top subspecialists in a very, kind of unique area should be able to get to whichever patients throughout the world need their expertise. Whether that's in sub-Saharan Africa or Asia or in the rural area of Appalachia here in the U.S. I'm optimistic. I think there's a lot of forward movement in this space, and I think increasingly, even public policymakers, both in the U.S. and elsewhere, are starting to think of broadband as, it's not just a convenient tool. It is actually really a public health type of tool that needs to be, thought of along with, all the other things, vaccines and everything else. It's a vital part of how we're delivering healthcare across the world these days.
Yeah, it's still almost surreal about how COVID has shifted everything. Things that I didn't think were going to happen for another 5 years. It's almost like they immediately happened, and everything shifted like overnight. It's crazy. So let's dive into today's topic: universal telemedicine, bridging gaps and challenging assumptions. In this episode, we'll dive deep into how designing telemedicine with the patient in mind can drastically change the healthcare landscape. David Fletcher with Geisinger Health System will share survey data and real-world examples that demonstrate why telemedicine isn't just a convenience for young technology enthusiasts, but can provide significant benefits across a wide range of demographics. So David, this is, medicine in general has always, been an interest of mine. As a kid, I wanted to be a doctor. I was pre-med. And so this is all very interesting to me. So I'm going to try to contain myself and not take us off track to kind of your area of expertise. But really, when it comes down to designing user experience, what role do you feel that user interface and user experience plays in building trust and comfort for telemedicine users?
Yeah. So, I think it's really key, and particularly because I'm very strong advocate that we must not think of telehealth and digital health as, kind of a niche product, a convenience for people of means, or something that's 20 years down the road once the millennials and Gen Y get to an age where they're demanding more healthcare. It really needs to be a tool for everyone, and so I think it's really important to be thinking in terms of, okay, what does the patient want, and what can they use, and so in the past, a lot of folks I cringe when people talk about okay, this is a great tool for folks, kids born with an iPhone in their hand. They're going to want to get on and do this, through their phone. We get it. But it's not really for, the older folks. And I completely disagree with that. And we've actually found a lot of survey data, our satisfaction scores are really high for patients over 70, 80. We've had patients over 90 use telehealth, and they love it because it solves a lot of problems for them. Often it prevents them from having to get transportation. I never forget, we had a survey response from somebody one time who said, I have a brain tumor, and having to go to your hospital and get in one of your elevators makes me sick every time. And it's a use case I would have never thought of, but it's that kind of thing that is so universal, that if you can really make sure this tool is available to everybody who needs it and not make assumptions about demographics. And then I want to highlight a couple of the words you used, which are perfect: the trust and comfort, because that is absolutely key when folks are designing these tools. And I'll tell you why, because that same survey I talked about with, our satisfaction scores were great in the low 90s. And most health systems are seeing something along those lines as well. But when we ask our patients, okay, great, you love it. Do you plan to use telemedicine, say, if we can get past COVID, will you continue using it? And I expected extremely high responses there, considering how satisfied they were with the service. But it was markedly lower. It was in the 60s percentage that folks at the time said they intended to continue telemedicine. And so I was curious about that disconnect. And so we asked them, okay, what concerns, if any, do you have about telemedicine? And the number one response was, well, I don't know that it's as comprehensive an exam as I get in person. And so I think that that trust and that comfort level, it's important to build that in. We have to think about what is going to make a patient feel like this is a true exam. We have to build in the elements of an in-person exam into the video exam as well, so that they feel comfortable that they're actually getting a full service and it's not just an emergency done because of COVID or some sort of public emergency.
Yeah, I would imagine that has a lot to do with what they're being seen for, right? Their personality as well, right? And so that's really cool. Like, the point that you made about you would have never thought of that use case without that person coming forward. And I think that's where a lot of organizations make mistakes in maybe designing products that they think people are going to want without really doing that market research and really talking to the people first. I learned how to build products or service lines from a company, from a system based in MIT through a technology incubator here called Geekdom in San Antonio. And through that system, it shows you basically that you need to go and talk to the public first, talk to the end users, and ask them what their problems are and what they want, and then you go and design that service or that product designed around what they want and what they're asking for. And I think a lot of times as leaders we forget that it's not about what we think, it's about what they want. So
Absolutely, I could not agree more. And I say that often to vendors who might pitch me on a certain product is like,
yeah,
you're solving a problem I don't have. I don't know why you thought that this would be helpful to us, but absolutely, like, focus on the patients first, and then let me know if you can help them.
yeah, absolutely. So of course AI is a hot topic right now, and technology is advancing so quick. How do you think machine learning algorithms improve the diagnostic capabilities of telemedicine?
Yeah, yeah, absolutely. I mean, I think there certainly is a lot of potential there, and of course, what you're getting a lot of ink written, spilled about. Oh, this going to replace doctors? Is AI just going to totally diagnose and give you a care plan? I've worked a fair amount with some AI tools and chatbots and things like that, and I'll be honest. I think we're still quite a ways from that even being a realistic consideration. However, I do think even as we sit today, there is a big role for AI to play, and the way we used it really was mostly about kind of triaging and guiding the patients to the right level of care. So the tools are good enough to kind of know if it's really acute, emergent. It's not necessarily going to land on the exact right ICD-9 diagnosis code, but it can give you an idea of the acuity. And it can also, the other nice thing is it can handle things where the patient is just looking for an answer for something. They want to know where to find their doctor's office, or they want to make an appointment or something like that. The chatbot's really good at then saying, "Oh, this has nothing to do with symptoms, but I can guide you over here." And so I think there's still a big role to play, and particularly for a lot of, like, health systems like Geisinger, where it's difficult to recruit to that area. So there are some subspecialties where it's we don't have an overabundance of access. And so there are national studies that show that even with a referral coming from a primary care provider, a skilled provider, 30% of referrals end up being medically unwarranted. And so what we often describe as, oh my gosh, we've got this provider shortage, and there is, but a big chunk of that is actually more of just a misallocation of resources, that we're referring people to these specialists that where that patient really never needed to be there. I think AI could play a big role in really helping to triage and streamline the referral process as well.
That's interesting. And that's something that I talked to my team about recently, right? It's something similar, but it's thinking about like what resources do we already have, right? It's like, we're very quick to want new tools or new ways or new solutions, but I think less often do we slow down and think, what are we wasting? What do we currently have that we're not fully utilizing, or we're not doing in the best, handling in the best manner, that's creating waste, right? And I never really thought of that from, a medical perspective, but that's a huge point. Like there's got to be so many stats that are being skewed because of waste, and exactly like that example that you gave. So that's interesting, very interesting stat. And I think that would also, I don't know how it would play into it, but I would think that would have something to do with prices increasing, potentially insurance premiums increasing, stuff like that, because of the perceived or the created shortage. Maybe I don't know. I don't know how that plays
Yeah.
into that, but I
Yeah.
would imagine it has some effect on it.
Yeah, absolutely. I mean, it certainly is, to whatever degree, anytime you just have, like you were referring to, yeah, even outside of medicine, this really scarce resource, but that is really good at doing a very specific task. Anytime you have that scarce resource doing something that isn't that task, it's economically inefficient, and there's enormous amount of that, unfortunately, in the medical field. So you might have say a maternal fetal medicine subspecialist. They're really skilled at handling high risk pregnancies, but you'll often find them seeing women who have a normal pregnancy, which is, I mean, and it's fine, they can certainly do it, but it's not the marriage of that, that scarce resource with that very specific skill set that they're trained for. And it happens all the time, all across the country. And to whatever degree, we just chip away at that. We don't have to eliminate it entirely, but if we can chip away at it, you're absolutely right. It can bring costs down because it'll send the low acuity patients to the right level of care, and then keep available the really high acuity access for the really high acuity patients.
Yeah, for the people that need it most, right? And
Yeah,
it's
absolutely.
there's some physicians that are just booked up. Like you have to wait quite some time to be able to see them. So yeah,
Months.
that's
Yeah,
that's a
absolutely.
huge issue out there. So now, what about like broadband infrastructure? Like what types of solutions are being implemented really to overcome connectivity issues?
Yeah, yeah. So, we had a program at Geisinger, that proud of. We won a couple of awards for it, uh, and basically the idea was, okay, we have a certain fairly small percentage of our population who uses an enormous percentage of health resources. And this is, again, true everywhere. It's, the old 80/20 rule. And certainly true in medicine. And so, is there a way that we can provide more resources to those patients and head off, some of the, say, readmissions to the hospital or unnecessary utilization of the emergency room? Um, and so, of course, we thought, well, great, digital tools will be fantastic for these patients. We can reach them in their home before they have an emergency kind of situation. Problem is, many of them did not have good access to broadband. And so, what we did is we would actually send out nurses or community health assistants, kind of lower level, less expensive than a doctor, resources into the patient's home, and they would help coordinate, social services, things like that. But we would also send that nurse with a kit that had a MiFi, so we didn't have to worry about the broadband issue, and it had a tablet and, digital stethoscope, an otoscope, a handheld camera, things they could plug into that tablet and bring in the doctor whenever they went and visited them. And so in that way, we were able to say, Geisinger has a health plan, and we were able to save that health plan $2 million in the very first year that we started this. And so we really ramped it up after that because we could show the value of it. Patients loved it. They were able to stay in their homes, have somebody come to them and help them. And it really helped unclog our emergency rooms and our hospitals.
Wow. Yeah, that's awesome. And so literally they would bring out like a little internet connectivity device and be able to kind of beam the doctor in, so to speak, to where he could be there on a screen consulting with them, and maybe they're taking a heart rate or blood pressure and stuff like that as the doctor's talking to them.
Exactly. The
Interesting.
nurse would place the stethoscope wherever the doctor wanted it. They
Mm.
could use a handheld camera to do a close up of a rash on their leg and things like that. And the technology has come so far. I mean, the stethoscope, I mean, we've had many doctors say they can hear the digital stethoscope better than they can the traditional one they have in their ears. And the handheld camera, same thing. It's really high definition. So the tools have come a long way, and it's a great way to treat those patients.
That makes me think about it. One of my son's friends' dad is a radiologist, and they're leveraging AI to read X-rays, right, or be able to identify things in certain types of radiology screenings. Um, is AI being used in maybe digital stethoscopes? Is that technology really there yet, so to speak?
Yeah.
Listening.
It's a good question. I don't know. I don't know if they're using that to tweak and make improvements to it. I will say already they've gotten really good. I mean, about 10 years ago, we'd occasionally get complaints from doctors. And I've found really in the last 5 years or so, even doctors who started out a little skeptical once they hear it in use they love them. I mean, they really are very sharp and clear.
I've
Um,
never even heard of
so
a digital stethoscope. I didn't even know they existed. So
yeah,
yeah,
yeah, no, they're
so
great. They're
I'm
fantastic.
behind the
Yeah.
times when it comes to digital stethoscopes, I guess. Yeah.
You probably don't have one in your medicine cabinet yet,
No,
but
I do have
someday
a
you
nice
might.
stethoscope. I do have a very nice stethoscope. I forgot the brand, but it's a
Yeah.
cardiologist stethoscope, but probably not the best at identifying the sounds, right? But I have a
Right.
little bit of practice and training on that at least. So let's talk about some like demographics, right? You mentioned demographics earlier. Alluded to stereotyping. You didn't quite call it that. I forgot what you called it, but I think as humans we have these. We kind of live in our own little universes, right? The way that we are raised, kind of how we're programmed when we're kids. We develop these belief systems, these worldviews, right? That lead into our stereotyping of different demographics from our own perception, at least. Or I'm sure society has a role to play on that as well. But like, what strategies do you think are effective in like including demographics who may be less familiar with technology and telemedicine programs, so to speak?
Absolutely. Absolutely. So I'm a big advocate for really standardizing a lot of the workflows and the tools that we use, that a health system would use for digital health, because then it allows that system to have standardized training and put videos out and things like that. So you don't have a decision tree of saying, oh, well, if you're having these kinds of visits, here's the tool you're going to use. But if it's another kind of visit, you're going to have to figure out how to do it this way. We really want one flow for everyone. And so you can do training videos. We would also do pre-visit calls. If someone hadn't previously had a telemedicine visit, we would call them ahead of time and make sure they were comfortable, make sure they had the tools they needed, things like that. Now, I will say I'm a big believer though that these kinds of tools should also be almost thought of as kind of market research in a way, because if to me, if a health system is having to rely uh, extensively on these tools, then that's a symptom of a greater problem. I think then that's a sign that system really needs to go back and look at their workflows and really redesign and kind of we were talking about earlier, really design the whole workflow and the product with that patient in mind, including ones who aren't electrical engineers by training. And so it really should be simple enough that it's pretty intuitive. Now you're not going to get everybody, I understand that, but if you're having to rely extensively on training folks, then I think you really need to rethink your flow. And so like Geisinger, we would send a link, just a text message. We had integrations built with our EMR and our electronic medical record and our scheduling process, so that we knew who that patient was, and we would just send them a link to their text message. They would click a link, and that was it. They didn't have to sign into a portal. They didn't have to remember a password. They didn't have to know how to download the latest, iOS update. It was like we made it very, very seamless, and we found that a lot of patients, that I always laughed. Our survey responses for the first 6 months after COVID, almost all of our survey responses started with the words "I actually," because it was always I actually thought this was easy to use. I did not expect that. Was kind of the general gist. And I was very proud of that, because I think it's why we had such success with all demographics using that kind of digital tool.
Yeah, that's a good point. It's I never thought about it that way, but it's like if you're having a lot of these things that are creating bottlenecks or problems with having to train too many people, I would imagine that, like just like you said, is if you understand what they really want and what the patient is asking for, and you build those into your strategy and your delivery systems, well, then theoretically you should have less and less of those needs for getting people up to speed, so to speak. But I don't think I've ever had like a telemedicine visit to where I didn't have to like input some information or potentially log in, which is really a pain. So I'm actually interested if how can I actually leverage this system? I don't know if it's in our area, but I've had some issues with having some telemedicine visits that were not very streamlined. Probably not ones that you guys developed. So yeah, that's interesting.
I'll be honest with you, it's a hotly debated topic in the
Mm.
industry right now, that a lot of health systems, for a lot of good reasons, kind of want to drive patients through their patient portal, with the hope that they'll also start to use a lot of the other tools. And there are a lot of really nice tools built into those portals. Now, there's an argument to be made, though, that, well, maybe that's great, and you should definitely encourage folks to do that. But if somebody doesn't want to, or doesn't have the technical skills to do that, you don't want to, to my mind, you don't want to withhold the ability to conduct a video visit. And so, to my mind, the best case scenario is kind of the both. You can get to it through the portal if you really use the portal and love it, but if you don't, we can still we have the technology to get you started in a visit, even if you've got almost no technical ability whatsoever.
Yeah, yeah. So, let's talk about telemedicine versus traditional on-site, right? You have to come in to visit the doctor. Can you help us understand maybe kind of that dynamic and maybe some pros and cons, or just maybe how it may, one way may and could enhance the patient relationship, so to speak, patient doctor relationship?
Yeah. Man, it's the $10,000 question, and it's a great one, and I think in a way we're in the golden age to be able to answer that question, because in the past that was always the concern. There were a lot of barriers prior to COVID around payment and regulatory issues, and people wondered, like, are these visits going to be as effective? Are they better in some ways? Are they worse? And we didn't have the data because no one was really paying for the visits except under certain very specific circumstances. And so, but now, like, we have enormous amounts of data, and I think it's really important that academicians and health systems really dig into that and answer that question. Now, I will tell you, anecdotally, there are a few instances where we hear that it's actually preferable to do telemedicine, and we hear it a lot in behavioral health, or mental health. The providers say, not only am I able to talk to my patients, which is great, but I'm able to see their surroundings and kind of how they're living. The patient's more comfortable because they're in their home, and I'm getting a lot of extra cues about their life circumstances that I wouldn't get if they're kind of in this kind of construct of my office building rather than where they live. So I think there's a lot to be learned in that space. At Geisinger, we did a pretty big analysis of all the telehealth that we were doing, and There's a lot of other benefits. Of course, access is really big, particularly in a rural area where we don't have just, a ton of dermatologists and nephrologists and things like that. Um, Anxious to move to central Pennsylvania. It's a rural area, and so we were able to improve access in many cases by providing telemedicine and things like that. So I think there's a lot of benefits, but we also need to look downstream too and see, are there benefits, but are there negatives with it? I think there's it's possible. There are certainly instances where a video visit gets disconnected, and we have procedures in place to try to deal with that, to either reconnect or at least finish via phone. But does that have an impact on the overall progression of that person's episode of care? I think there's a lot of data that needs to be weeded through, and I hope to see a lot of studies published about it.
Yeah. So it's a really good point that you made about the environment, right? Is because I'm very interested in holistic medicine, and environment. If you ever study epigenetics or anything, or just human development, the environment that people in has a big piece to play in their health and in their overall well-being. And I never really thought about that, is like you're getting kind of a peek into their world in a sense, if you could see some sort of background or hear some, what's going on. But specifically, I think, like you said, in mental health, like if somebody's more nervous around people or just being out of the house, right, you're going to get a more natural beat on kind of their normal state of being, I guess, if they're in their comfort zone, so to speak. So, yeah, I never really thought about it that way, but it's, I don't know. I
Clinical
hope it.
nutrition is another great example. I think some of our providers are really enthusiastic about it because if the patient was on their iPhone, they could just send, like, open your fridge. Let me see what's in your refrigerator. I mean, not in a collaborative way, not to try to tell on them, but or the pantry, and let's talk through, like, oh, this is maybe if you substituted this for that, and things like that, and it's really incredibly helpful to see, because you're in a provider's office, you're kind of presenting yourself as, and it's not how you typically live, it's just you're sitting on a cold steel bed, versus really kind of in your home, and can really show, like, here's what I'm actually doing on a daily basis, is anything I can do to help improve my health.
Nice. Yeah. So, with this shift that we've been talking about towards more client-centric healthcare, what are some of the outcomes, like improved outcomes for patients because of this shift that's been happening?
Yeah, yeah. Well, so, one really good example, I think, is again in behavioral health, but the no-show rates have gone down. At least at Geisinger, they did, for telemedicine visits. Um, so, obviously, there's just a lot fewer barriers for a patient. They don't have to worry about the car breaking down. They don't have to worry about getting off work in some cases if they're working from home. Um, and so we actually found, interestingly enough, when COVID first hit, we closed a lot of our clinics, just like everybody else, for safety reasons. And within about, I think, a week and a half of closing our clinics, we were actually seeing more patients for behavioral health than we were before COVID, because the no-show rate was that much dramatically lower. And so there were so many times where our providers were sitting there and not seeing a patient because the patient hadn't shown up, and we weren't able to substitute anybody in that quickly. So we were actually improving access over time just by having telemedicine available for our patients, which is a huge benefit for patients and providers.
Yeah, the convenience factor is huge with people, right? I mean, I think it's human
Absolutely.
nature that we don't really want to be out of our comfort zone, and then it's specifically for certain patients, I would think that the more excuses there are for them not to show up, it's going to be easier
Yeah.
for them not to show up, right? If they have to drive across town or be in traffic or you know
Yep.
whatever,
Absolutely.
right? So David, we've talked a lot about a client centric approach. When it comes to the approach of a physician or a healthcare provider interacting with a patient and really taking more of a conversational approach to service or to providing healthcare to somebody. How is that really benefiting, or why is that important with today's state of healthcare?
Yeah, no, I think it's enormously important, and I think it again it opens telehealth availability up to a wide demographic uh, selection, and I think that's important. So, I think there's a certain assumption that okay, if we're just knocking out a quick telemedicine visit, no big deal. It's kind of a tech friendly group. We're just gonna, kind of quickly do a urinary tract infection patient or something like that. But if we really think about it as this is just how we're delivering care now, and it should be just like an office visit, we should be developing this relationship with our patients. Then it really has a lot more value, and it also opens it up to more than just the 20-year-old, who just wants a quick one-off visit. And so, I think we actually build a lot of training around that for the providers because, it's tempting, I think, when you're just on the screen and you don't feel like the patient's in the room with you because they're not. And the provider, can just be documenting and they're really just kind of looking at their computer the whole time, and we don't want that. We actually trained our providers, we called it webside manner, much like bedside manner, and I think it's important. I think we really said you've got to keep eye contact, all the same types of things you would do in a visit in an office. You really should be doing, and I think it's really crucial for health systems going forward because if these visits just become a commodity, you've got Amazon, you've got Walmart, you've got all these other companies that are moving into this space. And so if you're not building those relationships with your patients, you risk losing them, I think. And so, and I think, again, it's another one of those things that, that may be where there is a slight difference between older and younger patients. I think, the older patients want to feel like they have a relationship and may feel like, well, I may have other health needs beyond just this initial primary care visit. I want to know that I've got a provider who kind of knows what's going on with me, and so I really think it's important to build that in, and so that the patients really do feel like they're getting a full visit when they talk with a provider, whether it's via telemedicine, whether it's in person, should make no difference.
Yeah, and it's a good point because the vast majority of communication is nonverbal, right?
Absolutely.
It's eye contact, it's mannerisms, it's facial expressions, it's body movements, all of that stuff. And if it seems, I mean, if you're at a doctor and the doctor's just like over here looking off, to the left, doing this and talking to you, you're not going to get the same effect. It's like if you're meeting with somebody and they're just on their computer, right, ignoring you, it's gonna skew that. And I think that conversational approach is almost kind of like more of a coaching approach. And I think Stephen Covey said it right: 7 Habits of Highly Effective People. It's kind of seek first to understand. And if the doctors are understanding the clients and really trying to understand what their state of being is like and what their overall situation is, well, that's going to also increase the trust. It's going to increase the trust, potentially open up the patient. They're going to understand more about them and maybe identify a more deeper root cause to whatever they're experiencing. So yeah, it's interesting. The challenges of remote service now, I think the majority of us are feeling because we've all kind of been catapulted into it and had to just kind of learn on the fly. So it's interesting. So data, you mentioned data earlier, right? And as there's a saying, right, that data is the new oil, right? Like it's so important. As humans, we make decisions based on data. We're constantly taking in data and, we're making decisions based on it. How is data analytics really enhancing telemedicine?
Yeah, absolutely. So I think it's got a huge role to play, and particularly in because it's this way of seeing this number of patients is so new that we've really got to understand the ramifications of it, like we were talking about. I think the CEO at Geisinger one time asked me, okay, what all we he knew we'd stood up a bunch during COVID. It's like, all right, give me the inventory of what we've done. And so I was enormously proud of all these things. We were in hospitals, we were in skilled nursing facilities, ambulances, and 15% of outpatient visits, blah, blah, blah. And then he said, okay, great. Now, how do I know what the right amount is? Like, are there areas where we should be doubling down? We should be doing more telemedicine? Are there areas where, as COVID recedes, we should scale back? And the simple answer at the time was, I don't know. So I said, okay, let me get back to you. And so we spent about a year, really kind of analyzing, like, okay, what benefit are we deriving from this? And I think there's just enormous need for that. And particularly, I think as I talked to other colleagues, and it was certainly true at Geisinger as well, is we were sophisticated enough to know we would not offer telemedicine as an option if the providers didn't feel like they could get everything they needed for that visit through telemedicine. If that was not the case, we wouldn't even offer telemedicine, and that's generally true, or other health systems as well. But there's been a lot of studies about kind of equivalence of visit between a telemedicine visit and an in-person visit, and that's all great. But I think there's a lot more that needs to be understood about what does this mean just longitudinally over time across an entire episode of care. What is the optimal amount of telemedicine? And it may be that it's just a wash, and it's whatever is convenient for the patient, as long as the provider is fine with it. Maybe that's the answer, but I don't think that it's been shown kind of empirically. And so I think there's just a lot of data that needs to be looked at to see, because it may well be, say in a pregnancy, that that visit 1, 3, and 7 should be done telemedicine, and the other is in person. I'm just making something up, but that kind of granular data, I think, is available now for the first time, and I'm really excited to see. I hope that a lot of health systems are really delving into this level of data and really trying to optimize it. So one of the things I work in, I'm the vice president for Search, which is it's a nonprofit society where we put on a conference once a year to look at unbiased research, not from vendors, but just unbiased research for digital health. And as I say to them all the time, like, we're in a golden age, like we actually have all this data now, and we really need to be publishing this data, and so are policymakers, because I think honestly, I'm a telehealth advocate of sorts, but I believe policymakers are generally asking the right questions. I understand why they're a little bit skeptical and want to see, well, before we just turn this on full bore for all of time, sure would be nice to know, like, what are going to be the impacts. And we've got a lot of answers now. I think there was a long time people were worried, oh, this is going to be duplicating visits, and we basically answered that no, it's really not. But is there an impact on the overall quality of care? I think there's a lot of data that still needs to be delved into and published. Yeah, we should really be able to start to optimize. I think right now that we've gotten as far as, okay, more or less a telemedicine visit individually is equivalent to an in-person visit individually. But what does that mean across, like, say an episode of care, or like, say, a pregnancy? If you have, whatever, 9 months, should every visit be done via telemedicine up until the delivery? Should it be certain visits? That kind of granularity, I think, we've got the data now to really delve into that.
You can just ask
I hope
ChatGPT now. ChatGPT will know everything.
Right. Yeah, exactly. Ask ChatGPT. We'll see.
Yeah, that's funny. So, that's a good point. It's like the data has been collecting more and more and more. There's more and more telemedicine. I know I've definitely been, leveraging telemedicine. It's much more convenient. But, how do you think this is going to evolve in the next, 5 to 10 years from a like client-centric healthcare via telemedicine.
Yeah, absolutely. I think we're definitely going to see some big changes, and I think we're going to see a real continuation of really the patient being the hub of that patient's healthcare as it really should be, rather than say a given health system. So back in the day, the health system owned all the health records, and they just and it was you kind of went to the same place every time. I think increasingly patients are going to be owning their own data. They're going to be expecting to be able to make their own decisions and do things like self-scheduling and choose their provider. It won't just be calling a phone bank and be like, okay, who can you set me up with? I think patients are going to be able to expect to really drive a lot more of those kinds of decisions. And so, I think it's going to be really important for, kind of particularly the smaller and the medium-sized health systems to really adapt to this. I mean, I think, by and large, the larger health systems, they've all got chief digital officers, and they've got, they've built up a lot of infrastructure. And I think in the past, we've always, those of us in telehealth have often thought this is going to be telehealth will be a great equalizer for some of these smaller systems, because they'll be able to get access to subspecialists that, it wouldn't make any economic sense for them to recruit full time. Infectious disease specialist, you wouldn't have one at a 40-bed hospital. You wouldn't be able to keep them busy. But with telemedicine, we can say, hey, I've got access to an infectious disease specialist because I've got a card here and I can dial one in. So that's great, and that is helpful. But I think the flip side of that coin is that if those systems don't make these kinds of investments, the patients are increasingly going to begin to expect that they have all these tools available to them. And if they don't, then they're going to start looking elsewhere, because all of a sudden the geography of where that health system is matters a lot less than it used to. It's not insignificant, but it matters a lot less. And so I do worry that, and it would be tragic if we lost a lot of these, kind of smaller rural systems. But yeah, I think they do run a risk of kind of becoming a Blockbuster Video, where, Blockbuster thrived because they were on every street corner, and then all of a sudden it didn't matter where your movies were coming from. And so I think, health systems, particularly the small and medium ones, are really going to have to make sure to stay up to date on a lot of these kinds of digital tools.
Yeah, it makes me think of Amazon, just how it's been just wiping out competitors, so to speak, because of the ease of use and convenience. And, but I would hope that, there's going to be some multiple players in this space, right, that are going to have to compete, because then the way that they would compete, I would think, is that they're going to compete by giving better service and more convenient service. So, and as patients start to more and more own their own data and their own patient, control over their own patient data, so to speak, that these systems will have to compete for those patients to come to them, which could drive up the quality of the experience and service, for sure. That would be good. So David, we're coming up to time here. So, in your opinion, what technology does the world need that doesn't exist yet?
Boy, I think we're at this kind of pivot point with, we have all this data now, and we've got to figure out how to make sure it's usable. And I think the urgency for this has really been amped up by all the AI and this kind of these new tools that are coming out. And there's a little bit of a disconnect between these two things, because if the data is messy and has a lot of irrelevant pieces in it, then you're going to get bad answers out of whatever tool you're using, whatever AI process you have. And everybody's heard the stories about the legal case where it made up a case that had never happened before, things like that, and we kind of snicker about it. But in healthcare, it's a huge deal. If if the AI is confidently telling you something completely wrong. And I think there's a huge risk of that because first half of my career, I actually worked in data analysis and claims analysis and program evaluation in healthcare. And so I can attest, and many people could as well, but that, claims data and things like that, really messy. A lot of really easy to come to the wrong conclusion just looking at raw data. And so I think there's a real need for both kind of cleaning up data and figuring out, being able to cull out data that's not relevant and only send to providers, decision makers, clean and relevant data. And it's really hard to do, so even within a diagnosis code, they're pretty broad. Even if it's the correct diagnosis code, it doesn't tell you exactly what's going on with that patient. So I think there's a real need for kind of objective lab data and things like that are, is repeatable and is a very, accurate number. If we're going to really pile that into things like AI algorithms and things like that, which I think we should, but there's this interim step that needs to be done. And I think there's just a lot of work that needs to be done in that space for sure.
Yeah, I mean, there's a lot of work in general that just needs to be done in organizations to clean up the data, right?
Yeah.
And so to be able to benefit from it, but then, it makes me think about human nature is that humans are inherently flawed, and we're all kind of baked in cognitive bias. And that's something that we employ in our company, and we help our clients with is really leveraging technology and data to help them make better decisions based on that data, with getting past their own cognitive bias. But it's extremely important for that human to still be involved, to kind of take the data and then take their knowledge and kind of use it all collectively. But then when you talk about tacking on AI on top of that, it's like, humans are inherently flawed, and we're building these systems, and for us to think that these systems are not going to have some flaws in them, it's insanity. And so it just gets dangerous that you need to make sure that that human is still involved, and it's not going to be there for a very long time to where we can trust an AI system to take all the data and then just give us the the black and white answer, so to speak.
Oh, I totally agree. I think there's a real risk. It's only going to amplify that the biases that we have that are already kind of baked into our data. And so as an example, so a lot of folks believe that older folks can't use telemedicine. So if you just look at the data, you would see that a lot of systems, they don't even offer it, say, to older patients. And so AI may get the impression that well, maybe that, telemedicine isn't used by older folks. Doesn't mean that it can't be, and so I think that's where, we as health systems and humans need to really be thinking through these things. And so like one thing I've worked with, West Health is another nonprofit, and they focus on particularly for healthcare for aged. And so they've started this group called Center for Excellence for Telehealth and Aging, CE4TA, and they've set up guidelines and things like that for health systems to really think about, when you're designing a telehealth program, maybe think about, is there going to be a caregiver? Don't just think about, oh, well, I assume it'll be the patient that's going to be just dialing in to see the doctor. Maybe they have a caregiver, a child who helps them with all their visits. Factor that in, and so as part of this, they have a pledge they ask health systems to sign that kind of supports that I'm going to build my telehealth with older folks in mind. I think these kinds of things are going to be crucial if we're going to really have good data coming out of the AI, even 5-10 years from now, because we've got to really include everybody and not build in kind of our initial biases about who can and can't do things.
Yeah, it's interesting to see how all this stuff's going to play out. It's it's still kind of surreal about how COVID's been playing out, but then the power of ChatGPT and that coming out, and the accessibility to so many of these tools now is just like, it's still kind of surreal. But we'll see how it plays out over the next few years for sure. So David, Thanks again for joining us today and sharing your insights. Very enlightening. A couple more questions here, and we'll wrap it up for today. But I'm curious. We covered a lot of topics. You have extensive experience in the space, obviously. How do you hope to help advance patient-centric care?
So, what I'm really focused on now is, I'm doing consulting with a lot of, with health systems and like West Health, like I mentioned, they're doing a lot of work for telehealth for aged, and I work with them quite a lot. Again, I definitely encourage everybody to look and sign that pledge if you agree with me that telehealth should be available to all demographics, including older patients. Um, and so I've got people. I'm certainly very happy for folks to reach out to me on LinkedIn. I'm David-Fletcher-Telehealth, and happy to share anything from my experience. Like I said, I'm doing consulting, and I also kind of affiliated with Pivot Health Advisors. So my expertise is really in telehealth, digital health, healthcare workflows. But I also know people who do things in HR and crisis management and things like that. So either if I can't help you, I probably know somebody who can. So happy to have folks reach out and help in any way I can to really kind of advance this cause, because I really deeply believe that these tools can be used by just really any demographic, older, any sort of economic status. We've just got to think about how we design the tools.
Yeah, think about the overall solution and how to get it to them. Well, again, really appreciate your time, David. Listeners, be sure to check out David's work and follow him on social media. Website links and social handles will be in the show description. And finally, David, as a leader in tech, what's one piece of actionable advice that you can give to emerging leaders, really that are just starting to navigate their own paths in the telehealth field?
So, story I always like to tell is, kind of one kind of career detour I took, but I learned a great deal from it. And so, the main thing I always tell folks is, particularly in healthcare, to my mind, you almost always have two major customers. You have patients and providers, and you have to kind of think of both of them in everything you do, because what the providers do often impacts the patients in a major way, and patients tend to rely on providers for their expertise. So it's important to think of both of them together, and any kind of tool or new workflow, whatever you're looking at, I think really you have to look at it. Are you solving a problem for at least one of those groups, and preferably both of them? Because if you're not, if you're just kind of enamored of kind of the new toy and you try to throw it on top of them, it's not going to work. So the example I give is I worked for a startup in Nashville, Tennessee for a while, and years ago, and disease management was kind of all the rage at the time. It was this kind of burgeoning industry, and the idea of it was, oh, we're going to find people who have had a heart attack last year, or congestive heart failure, or diabetes, something like that, and we have this bank of nurses calling them, and they'll kind of talk through life choices and things like that, and get them on a healthier path. It's a great idea in theory, but what we found was the patients didn't really want to sit there and talk about their disease states with a nurse who they didn't know at all. And so it was good in theory, but we didn't kind of start from, is this something that the patients really want? Payers wanted it, but the patients didn't really want it. And so what we found was all the cost savings that these kinds of programs were showing were just regression to the mean. It was just, if somebody had a heart attack last year, they probably weren't going to have a heart attack this year, whether you did anything with them or not. And so it really, I learned a lot from that, is that don't just build this whole company or solution around what something in theory sounds good, like, oh, this will save money. You've really got to start with, are you solving a problem that the patients and the providers understand and want solved in a way that works for them? And so that's how I've really always tried to, any sort of I stay very abreast of all the new tools and programs coming out, but I always look at it through that lens. Is like, is this solving a problem for providers and patients? and is it a tool that they'll enjoy and really want to use?
Yeah, and it's a tough one, right? Because we get excited about how we want to serve or help, and we have to just slow down and look at it from another perspective. We need to look at it from the perspective of who we're trying to help, right? So thanks again, Dave. Really appreciate your time. Audience, don't forget to help your fellow tech humans. Share this podcast and follow me on LinkedIn at Javier Guerra 360. See you next time on the Tech Human Experience.
The Tech Human Experience